Good afternoon, everyone. Welcome to our next session in the CDC's core infection prevention and control practices for safe healthcare delivery in all settings. Today, we're going to have Bernadine Miller going to be talking about infection prevention and environmental services. Before we get started, though, there's a few housekeeping items we'd like to go over as usual. So if you're not familiar with who the IPRO QIN-QIO is, IPRO holds the federally funded Medicare QIO contract for the 12 regions shown here. Specifically, IPRO helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the IPRO QIN-QIO banner. So if anyone asks if you're working with IPRO, you say yes. And Mary Ellen, would you like to give us a COVID booster update?
Sure, thanks Josh, and hi everybody. The COVID update for this week, hospitalizations again are down by 6%, the 7-day average about 3,400. Bivalent booster again creeping up, and this is as of the 23rd of February. 53.3 million have received the updated booster. 41.3 of adults 65 and older have received one, so ticking along little by little. Variants have not changed. Again, we're seeing some very consistent numbers with XBB being the dominant strain, and there's no sign of seeing any other different circulating strains at this point, so that's good news. Next slide. And then again, we like to give a snapshot of where the NHSN reporting is for nursing homes that are reporting their up-to-date vaccinations. And again, every week there's a small uptick, and that's really great news. Again, knowing how hard this work is and getting people to that slow yes, we're at 53%, up from 52% last week. So that's great news. And that's it.
Perfect. Thank you so much, Mary Ellen. So at this point, I'd like to introduce Bernie Miller to get us started with our topic. Bernie, I don't know if you wanted to just give a little bit of a background for yourself before we get started.
Sure, be glad to. Good afternoon, everybody. My name is Bernie Miller. I am an infection preventionist. I've been doing infection prevention since 1999. Been doing this a very long time. I've been certified since 2003 in infection prevention and control. 15 years of my infection prevention experience has been in the long-term care setting, but I've also worked in the mental health setting as well as the acute care setting. So I hope that I can share with you today some experience that I've had over all these years in the long-term care setting. I'm glad to be here with you.
Perfect. Thanks so much, Bernie. And we'll get started. Let me know when you need to advance slides.
Okay. So the first thing I just want to share with everybody is that when we look at our facilities as a whole, we are in this together. Infection control cannot operate in a vacuum. We fan out, we know we work with nursing, but we also have a relationship or need to have a relationship with support services and even administration. And so today I'm here to talk about one of those relationships that we absolutely need to have with support services, and that is our EMS folks. Next slide. So I'm going to first talk to you about guidance that we have from the CDC. You are going to have these slides where they're going to get sent to you if you don't have them already. And this is a link to the CDC core infection prevention practices for healthcare delivery and settings. Next slide. And for us, this is the core practices under environmental care. And the practice says that we require routine and targeted cleaning of environmental services as directed by the level of patient contact and degree of soiling. I think most of us are probably okay with this, but it doesn't hurt to make sure we're doing it. That we are to clean and disinfect surfaces in close proximity to the patient and frequently touch surfaces in the patient care environment and on a more frequent schedule compared to other surfaces. So those surfaces in the patient patient room that we consider high touch services, including remotes, the bed controls, all of that. Anything that we're in there touching all the time needs to be on a more frequent schedule than the regular cleaning in the room. Thirdly, promptly cleaning and decontaminating spills of blood or other infectious materials. Hopefully we're doing that. And then really importantly, which I will speak to on a slide, selecting an EPA registered disinfectant that has microbiocidal activity against the pathogens most likely to contaminate the patient care environment. So what is in our environment? What are we seeing? What is causing the infections? And does our current hospital grade disinfectant kill these organisms? And is it an EPA registered disinfectant? And then lastly, following manufacturers' instructions for the proper use of cleaning and disinfecting products. We call these IFUs. Next slide. So what is most important for us as infection preventionists is knowing what organisms are causing infections in your facility. What are the multi-drug resistant organisms that we're seeing? Are we seeing C. diff? I assume we are. COVID, yes. Norovirus and influenza and other ILIs. So that is so important because it's going to drive what disinfectant we're looking for. Next slide. So here is the hierarchy of resistance among microbial classes to germicides. So the disinfectants, the larger balloon that we call them is germicides. And so this is important to understand because look down at the bottom. So what this means is very easy organisms to kill. And look what we've got there. HIV gets everybody worked up. Hepatitis B, COVID, RSV, a lot of what we've been seeing. So these are what we call enveloped or lipid viruses, and they're at the bottom of the food chain here for microcidals. So then we have vegetative bacteria. This can be a lot of our MDROs, Acinetobacter, if we're seeing that. Next we see is fungi. Candida auris would be under here. I'm going to talk about that in another slide. But then look at this. We have our non-lipid viruses. And here comes norovirus, the beast that causes us all grief. But I also want to point out that we have enterovirus there and rhinovirus and adenovirus. These are actually another name for common colds. I don't know how much testing you all are able to do when it comes to respiratory illnesses. If you are able to have testing done on a biofire machine, that is a machine that actually will actually test for up to 27 viruses that are in the respiratory tract, and you can often pick up these adenovirus, and rhinovirus. So the enteroviruses and the norovirus are more the GI tract. We tend to see that with diarrhea and vomiting. So we may be seeing these in our facilities. I know we're seeing norovirus, so we want to make sure that we have something that we go to when we know we have norovirus. And then we have tuberculosis, and then at the top, those bacterial spores. And C. difficile, we know that when it comes out of that vegetative state, starts to form the spores, we can have an environment that is actually saturated in these spores, and we can start to see spread of C. difficile. We can actually even see outbreaks from spores in the environment that are not being properly cleaned. Next slide. So, what products are being used for cleaning and disinfection? Please meet with your EVS leadership to review and learn about the products that are in your facility and what they're using them for. You may be shocked to find that they're not sure what they're using them for. It's okay. Don't get nervous or more upset if they're as confused as you are. It can be a learning process for a lot of people. We have had a tremendous turnover of staff throughout all facilities and all different departments with COVID. So it may be a learning curve for all of us. You want to review the efficacy data sheets for the particular product. Does the disinfectant kill the organisms that are causing infections? This can be obtained from the vendor. You can often find this online when you look up your disinfectant, but most of the time it's actually even on the container of the germicidal. Many of our pop-up wipes, the pop-up disinfectant wipes, you will find it right on the tub what this germicidal actually kills. And then the goal always is to work together and to help each other. Do we have something that is going to kill C. diff? Do we have something that's going to kill the MRSA, the norovirus? And God forbid if we end up with Candida auris in our facility, do we have something that will kill the Candida auris? Next slide. So how do we know? So this is our alphabet list. I call it the alphabet soup list. This is actually something you want to bookmark when you get this. And there's the link for it right there in the chat. And this is what tells you what kills what. So go to the next slide and I'll explain. So this is why I call it the alphabet soup, because the list are given a letter of the alphabet. So I just put a few of them up there, but when you open the larger list, you're going to find a lot more letters. So the N list is all COVID approved disinfectants. The H list kills MRSA and VRE. The Q list is a monkeypox. This became, we recently had an outbreak of monkeypox in Uganda. And so those of us, so I failed to tell you this, I'm so sorry. I currently work for the VA of Maryland, and I do work in long-term care at the VA, but I am part of a team that is also the acute care team. So we started looking very quickly at what was killing monkeypox in preparation for that. And then the P list, which I would ask you all to look at, and some of you may have already dealt with Candida auris in your facilities, tells us what kills Candida auris. The thing to remember is that the companies are paying to get their names on this list, but it becomes critical in knowing what kills what. And you will find that if you have kind of a broad spectrum hospital grade disinfectant germicidal, they will be on multiple lists. And so once a company decides they want their product on these EPA lists, they will pay to get them on all of the lists, and they do the testing. And that's what's so important about this. The testing has been done to assure that these disinfectants kill these organisms. Next slide. So what do we do with environmental services? What should be something that we are actively looking at in our own environment that we work in? Educate yourself on any EVS or EMS, whatever you call that department, policies and procedures. Know how they clean a room, and that is so important. Get to know the environmental services staff. They're probably having the same turnover as nursing is having, and you may go out on the unit and not even know who these people are. But get to know them on a first name basis. I cannot stress this enough. They are often the lowest paid people in our facilities, and yet what they do is critical to helping us in infection control and prevention. So we want to befriend them. They are not our enemy. We need them to help us to eradicate infections. You want to find out about that cleaning schedule for ES personnel. What are they doing and when? What are they using and for what? And I will tell you, after years of doing this, and it has not changed no matter where I work, when you ask them this, they often do not know the answer. They are kind of making it up as they go along. They are often hired, given very little training in what is the proper way to clean a room, and they're just being thrown out there to start cleaning. And I try to make it the point to help them with knowing the policies, helping them to understand what products work for what. Oftentimes, if you're out and about and speaking with them, they don't even have the products on the cart that they need to do the job that they're being asked to do. And sometimes it's just a conversation with their director or their supervisor, and it's a calm conversation. It is never condemning. It is never, and I got you. If we get into I've got you or I've caught you, we are going to lose the forest for the trees. We have to help each other. They need us and we need them. And then if they have any vendor training that is going on, ask to be invited to it. If they're not having any vendor training, maybe suggest that to their supervisor. Hey, let's get these vendors in here. We are buying their products, and part of their job is to help with the training. You could have the best products in the world, but if nobody's using them, they're not going to do anything. So the more we can get the vendors in there, they should be doing this free of charge. It's a win-win situation for all. Next slide. Get on a committee if I know you're probably like screaming at me from the rooftops. We need to be on one more committee, right? But certainly if there's a products committee or an environmental services committee, you would want to be on that or certainly be aware of it. And you can also assist EMS in asking vendors for other facilities that are using their product and get their feedback. I do this quite frequently. We did this recently when we were bringing in UV light into the acute care side of the VA. And I asked the vendors, what other hospitals are using your product? And we called them. And for some of the products, we got very good reviews. For other products, we did not get very good reviews. That's really important when you're getting ready to go out there and spend a lot of money on either a big ticket item purchase, but even for cleaning products. And then again, I just want to stress this: have the staff tell you how they clean a room. Talk to each other. Monthly check-ins, or when you're out and about on the unit during their rounds, just speak to them, say hi. It can even be a casual conversation of how's it going? How are things at home? Whatever, how was your vacation? It will go a long way, because when you need them to step up to the plate, those interpersonal relationships matter. And then you want to communicate any concerns or findings that you find when you're out and about. You would want to do that with the supervisory team. You can certainly share it with the folks on the units, but that really is more appropriate for the supervisors. Next slide. You can also make disinfectant product selection a function of the QIPO or Infection Control Committee. I know many of us in long-term care just have a QIPO committee and we sit on that committee. EMS should be on that committee as well, EVS, but we can also discuss these products so that everybody is aware, why are we using what we're using? If you've already are using the proper product and you know that, that is not a bad thing to take that to your QIPO meetings. Again, so everybody, nurse managers, even dietary, everybody is made aware of the products we have and why we chose them. And then if you are doing any kind of training, new employee training, or you're out on the unit doing any kind of infection control training, show and tell these products, especially the disinfectant pop-ups. And even if you have distribution centers in a janitorial closet where that gets measured out, you're pushing buttons and it's measuring out the proper amount of cleaning solution, disinfection solution, and water. You want to show and tell those products with nursing. If nursing can get into these closets, but they don't know what to do with this stuff, it, again, kind of useless. And we all know that environmental services, it's not like we have a full throttle team on the units at all times. Next slide. Okay, IFUs, instructions for use. Anytime we buy a medical device, it can even be small devices such as IVACs, Dynamaps. It can be anything, even big items. You want food pumps, IV food pumps, any IV pumps. All of these products come with IFUs, instructions for use. Infection control and prevention needs to be aware of these purchases. Even when we buy beds, they come with IFUs. We need to read these IFUs and especially concentrate on the area. There will always be an area in the IFU that says instructions for cleaning and disinfection. We want to make sure that we have the products that these IFUs are recommending. Sometimes things, however, just need to be replaced. And I don't say that lightly, but there is just some things. For instance, if we have to take an item, I'll just use an IVAC, for example, and that's probably a poor example. But if we had to keep going into rooms that have C. diff, and we know that the product that we have for C. diff, we have to wipe this product down with bleach wipes. And the IFU for this IVAC says don't use bleach on it. Okay, well, we have to use bleach on it if we want to make sure we're not spreading C. diff from patient to patient. And it may be that we ruin the piece of equipment. We have to talk that out. We have to weigh the risk out. We don't do it arbitrarily, but we are speaking to one another about here is our risk. If we don't do this, here is the risk. With some equipment that might not happen, but we want to make sure we have compatible products that are working. Now, you may run into with these IFUs actually branded products. Again, companies are paying to have their particular product brand named in the IFU. So it may say Clorox, you have to use Clorox products. Now, if you don't have Clorox products, it doesn't necessarily mean that you can't use what you already have. If it is a compatible product, what you would want to do just to satisfy surveyors is to actually do a risk assessment. And a risk assessment is that it can be written out, typed out. You are aware that the IFU for this piece of equipment calls for Clorox germicidal bleach wipe. We currently use X bleach wipe and have determined that it is compatible. That is acceptable. You just don't want to be blindsided if a surveyor would say to you, do you understand what this IFU says? What are you using? You want to be able to speak to the IFUs. Okay, next slide. Okay, I have this slide here for two reasons. First of all, our position requires that we are out there. We are a cheerleader. We need to be out and about. The staff need to see us, and we need to be the person who sometimes has to lead the charge. Okay, guys, we've got a problem, and let's all get together, and how can we fix this? On the other hand, you don't want to be the person out there who is yelling at everybody. If we get out there and we are telling everybody everything that they're doing, that is wrong, and they're not doing this right, or they're not following this policy or this procedure, we will lose everybody. And that is not what we want to do. We need to be the cheerleader. We need to be the helper. I call it, sometimes I'm the servant out there trying to, especially with environmental services, trying to help them. Are there any questions before we move forward from the chat that need to be addressed on anything I've spoken about so far?
I don't see anything currently, Bernie. Actually, Jessica just writes in where to document risk management on IFUs.
You can actually make a copy of the IFU if you'd like to do that, and have a binder of these IFUs. We shouldn't have, it's not like an acute care. And in acute care, I will tell you, and even in, I made a copy of the IFU and I had a binder. And the tab on my binder, I'll make it up again, said IVAC. And I had the IFU there, and I had the risk assessment of what the different product that we were using. It's that simple.
We have another comment. How can we talk about biofilm in sinks? How are people cleaning their sinks to address the biofilm issue? I don't know if you're going to address that later on, Bernie.
I am not, but if that person could clarify more, biofilm, are we talking about biofilm in the drain, or are we talking about biofilm in the spigot? If they can, you see anything there? Let me put up the chat.
Yeah, I don't see anything.
Okay, well, we can come back to that. I don't mind
Yeah.
talking about that, but we're talking about two different beasts here between the drain and the spigot. So let's move on, and I certainly can answer any questions. So I wanted to talk a little bit about best practices. And one of the things, if we're not using this already, we need to start researching, understand it, and start speaking to environmental services, is the use of microfiber. So microfiber is we use it in our homes. We all should know what microfiber is right now. It actually did start out in the healthcare setting. And what microfiber does, the block, the upper left-hand corner explains it. It actually picks up organisms as it's cleaning, to where cotton fiber oftentimes is pushing things around. And it has to do with how small the threads are of the microfiber and the space between the threads. Microfiber can be for wet cleaning of floors, which is illustrated by the mop system, and also by the color-coded rag system, which I will speak to. Next slide. So here are the advantages to the microfiber mops. It absolutely eliminates cross-contamination. You use a clean mop head and clean rags for each room. So we do not put things back in buckets and move on to the next room. We could probably spend a half an hour talking about microfiber systems, but it is very easy to educate yourself on these systems just by Googling it on the internet. And if you do decide to move to a microfiber system, the vendors are more than happy and will train everyone up on it. It reduces the amount of chemicals and water that is used. You do have a wash lifetime with the product, and it varies on the grade of the microfiber. What you get is kind of what you pay for. The higher amount you invest into these microfiber mops and cloths, the longer longevity you'll have with cleaning. They are extremely lightweight, so ergonomics plays into all of this as well. I have had the pleasure of working with an EVS team that moved from just the regular cloth, cotton cloth and buckets, and moved into a microfiber system, and the staff were ecstatic. So it really does help. Next slide. Okay, and just the other thing is, I didn't put any slides because of time, but if you go online and look at microfiber systems, it actually does show you how they work and why you don't need these large buckets of water anymore. Okay, I'm gonna change gears now here. Here's another shift for us. Validating cleaning and disinfection. So the question is, how do you know that the areas that are being cleaned by EVS in your facility are actually cleaned and disinfected? So the CDC has a whole document, options for evaluating environmental cleaning, that they put out in 2010. So 12 years ago. And many of us are not doing this, haven't looked at it, haven't even thought about it. But we know more than ever now that the environment plays a role in the transmission of organisms. It has been well documented, study after study. It probably plays just as much a role in transmission of organisms as our hands do. And so this should be a quality measure for environmental service departments. So if you have a department that says, we don't know what to do for QAPI, this is something they can do. And there's many ways to do it. I'm going to run us through a few. Next slide. We want to start small. Please, please start small. If you don't, you will overwhelm yourselves. What is realistic for your facility in a workday or in a particular area? So when we're starting this, we can say, okay, we're really not ready to do the whole facility. Let's concentrate on our skilled unit. That tends to be where we see most of our infections coming in. Folks have been in the hospital. So you can start as small as just one unit. That is okay. Something is better than nothing. You want to work together with your environmental service team on a validation plan. And what I mean by that is validation for terminally cleaned rooms. That I have a star there is because that's another way of just starting small. We're just going to validate terminally cleaned rooms, and we're just going to work on one unit. That's a small piece of the pie, and it's doable. But then you can also spread out to validation of occupied rooms. How do we know that these occupied rooms have been cleaned? So the big question is, what are we going to validate and how are we going to do it? Next slide. So here are the best practices. Go ahead. Next slide. All right, the what. What do we want to validate? We want to identify what are the high touch areas in these patient rooms. We know what they are. Here are some examples. You can actually have fun with this. Let's 4 of us go into a room and brainstorm. What are all these high touch areas that either us or the patients are touching? So identify what they are. For the actual validation, you want to decide on how many surfaces you will choose for each validation. So maybe we go into the room and we identify 20 high touch surfaces. Before doing this and starting small, we're just going to say we're only going to look at 6, or we're going to just look at 10. And remember, think about the time this will take to do and start small. Another thing we want to think about, how many rooms do you want to capture each month or each week? 5 on the unit, all the terminally cleaned rooms, or we're just going to concentrate on C. diff rooms. We're going to take it down even smaller. Again, something is better than nothing. And once you get good at what you started at doing small and people get used to the process, then you can spread out. But don't try to conquer the world if you've never done this before. Next slide. Okay, so how do we want to do this? We've identified that we're just gonna do C. diff rooms, and we're only gonna look at 10 surfaces. How do we want to do it? So you can do it by direct observation during and after cleaning. That is extremely tedious. It takes a lot of time and it takes a lot of people. And most folks, when they have people watching them while they're cleaning a room, will actually do what you want them to do. So it's not always the best way to validate. You can do competency evaluations. And what that means is that you start off with making sure that the EV staff knows how to clean a room, that they're taught, and that they actually do a return demonstration. So that they know how to clean that room before we start doing further validation. And that's important. And then you can certainly get resident and family feedback. That could be a simple survey about the cleanliness of the institution. If you're going to do that, make sure that everybody knows you're going to do that, including your administrators. and get ready for some of the feedback that you might get. Again, that is something you might want to think about down the pike. Next slide. So here's another how, and this is something that I highly recommend. It's simple. So all of us should be familiar with GlowGerm. If you're not, just Google GlowGerm and you will get to their website and you will find everything you need to have to purchase GlowGerm, and it is not expensive. So what we would do is prior to the terminal clean, so we know this C. diff resident's getting discharged and this room needs to be terminally cleaned. I would go in and secretly place GlowGerm with a Q-tip or a swab on the areas I have chosen. So I may have, and you're going to see these sheets. You will have, I'm going to show you all of this, these sheets. So say we've identified, again, we have 20 high touch areas on a piece of paper, but now for this particular room, I'm only going to circle 10. You make sure you circle what you're going to hit with the GlowGerm, because you won't remember when you go back in the room. You have to know what you're going in there and hitting with the GlowGerm. So I take a little bit of the GlowGerm on the Q-tip swab and I go and hit these 10 high touch areas that I've identified. Then we let EVS go in and clean the room. And then afterwards I go in and see if the GlowGerm has been removed using the flashlight, the little flashlight. The flashlight is a glow light, a blue light, and you will see the GlowGerm light up if it's not removed. This is always, always, always to be a teaching moment and not punitive. If you see that this whole process is moving into some kind of punitive system where folks are getting written up, it needs to end, because that is not the purpose of any kind of validation. Validation, and for QAPI purposes, should always be teaching and improvement. The only caveat I have here is a warning. If an area fails, make sure you can remove the GlowGerm. And I say this especially for light switch, what are they called? Covers. So many of us have stainless steel light switch covers where we're flicking the lights on and off. And we found that the GlowGerm actually can get down into those grooves and it becomes very difficult to get them out. So the GlowGerm will often light up. What I ended up doing with that is just kind of mentally, when I would place it on the light switch, is trying to keep it on the light switch, on the little black switch or beige switch, and not smearing it all over the stainless steel guard because of that. But then you can also take a look and see that some of it's been removed. Certainly, if these areas are getting hit with a disinfectant wipe that is saturated, it is killing organisms. But this is a really quick way to do this. So just one way. Go ahead, next slide. I'm just putting this out here. This is ATP testing. This is a very expensive system that most acute care hospitals do use. This is actually a way of going out and testing for biological organisms. And this machine actually can read this in the environment, and it actually downloads onto a software system in your computer. Some of us in long-term care may have this based on some state patient safety initiatives that were done. I know in the state of Maryland, many of us who participated in a state safety initiative were given these machines free of charge. But I would suspect that most of us do not have them. They are extremely expensive. They are great to use and they are fun to use, and they are the real McCoy. You can actually test, we tested cell phones and we had staff who were like horrified. You want numbers of about 25 to 50 that are considered clean. And we had cell phones that were reading 5,000, 6,000, 7,000 that nursing is carrying around with. So, but they're very expensive. They're about $1,500 to $2,500 for these systems. So I would suspect that most don't have this, but I do want you to be aware of it. Next slide. This is an example that you do have when we get to the resources. You will have a link for this particular checklist. And as you can see, you can right at the top, everything that you need to know. And then along the side are all of the high touch areas. This is a pretty extensive list. It's easy, it's done. You don't need to reinvent the wheel, and you can also just curtail it for your own use. Again, this doesn't need to be fancy. It's just something we need to do. And you check off if it's cleaned or not cleaned, or maybe the area is not present in the room. This sheet actually would consist of testing or looking at every one of these areas. I suggest in starting small, you can highlight in yellow or circle the areas that you're going to go in there with the glow germ. Next slide. Next steps: education, education, education. I cannot stress it enough. EVS, Environmental Services, needs to know why they are doing this. And again, it should never be punitive. It's a quality measure, and it's validating for them how effectively rooms are getting cleaned. And they need to be on board with this. If they sense that this is something that is going to be punitive, we're not ready to start. They should understand all aspects of the process from the beginning to the end. And we can even, it's not bad to make it competitive. I used to, everybody loves chocolate candy. We would do this, and I would give like little pieces of chocolate to anybody who got an 80% or better when we looked at the rooms. And once we started doing this, and the staff, the EVS staff knew that we were doing it, they would want to say, "Can I come with you?" They wanted to see me go back and look at the room with the black light to see if they could see anything. And they wanted to do a good job. Will you have those folks that are slackers? Sure, we have that in nursing. We have it everywhere. But for the most part, I found that the staff, the EVS staff, they wanted to be validated. They wanted to get the kudos for doing a good job, and they wanted to do a good job. Surprisingly, I will tell you, where I rarely found anything dirty was the bathrooms. People know that bathrooms are dirty. They don't realize that light switches can spread diseases, or patient bed railings can spread diseases, or the remote that never gets wiped down to the TV or to the bed or to the call light can spread diseases. That's where we found it, on these high touch areas that are kind of like out of sight, out of mind. Did not have problems with bathrooms. So they just need to be taught. And then you can continue with ongoing education and competencies. I would include their vendors coming in and helping these folks, and then share what you found with the staff. If they have a bulletin board in their break room, try to make it fun. You can give out gold stars, you can do whatever. But we did start a little bit of friendly competition when I was at the last facility, long-term care facility I was in. And as soon as we started it, the results skyrocketed. People were like, "Oh, no, 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 you're not going to find this in the room I've just cleaned." So it was kind of fun. And then I would do stuff like I said, they're the most underpaid people. I would buy pizzas for them. I would go, I don't know if you have Little Caesars where you live, but like $5 for a cheese pizza. I would be like, "I'm buying you guys lunch." It's a thankless job that they have, and we need to cheerleader them. Next slide. We should collect this data and report it to the QIPO Infection Control Committee. Let's not work on a performance improvement initiative that we're not reporting to QIPO. We want to get credit for that. And then we do need to be involved in this. We need to help with the education, the observation. We may even be the ones who are out doing it. I don't recommend that the environmental service staff are the ones out there marking the rooms and cleaning up. It's kind of a conflict of interest, but we can certainly get nursing to help us. We don't want it to be a trip up, like, oh, I'm going to really hide this like under the mattress. We don't want to do that. We've got enough fish to fry with stuff that's right in front of our faces. And then we want to review the data with them. We want to say, hey, this is how we're doing, or look, this person is 100%, 90% or greater every time we look at the rooms that they're cleaning. Maybe you want to get them to kind of help these folks that are struggling. Next slide. And here are the resources that I've used. I would recommend, especially for these first two bullets, we do have environmental guidelines from the CDC.
Hello.
Bookmark this on your computer. We also have disinfection and sterilization guidelines from the CDC. Please bookmark these as well. And then here are some checklists that you have, but all of this is to help simplify your life, not to have to reinvent the wheel. Any questions? Oh, yes, more. There's some more resources there. Yes.
Thanks so much, Bernie. Do we have we do have a couple questions in
Sure.
chat that we can go through, but if anyone wants to write in any questions in the meantime, we'll get to those as well. I don't see that Christine had clarified about the biofilm, but we have a question from Brooke saying, can you speak to using alternative products on devices and warranties, i.e. glucometers, using a PDI bleach wipe versus Clorox?
Yeah, as long as it's a bleach product, you're fine. I think you just have to make sure we're comparing apples to apples. So if you know that the IFU is calling for bleach, do you have to use the Clorox bleach? No, you don't. Like I said, they're paying to have their name in that IFU, but you can't use a quat. You can't say, okay, this risk assessment, we're just going to use a quat. You want to be making sure you're comparing apples to apples and there are many different quats out there with different names, quaternary ammonium disinfectants. And that's why I said it's so important that you educate yourself as to what are the products that you have out there. So as soon as you do see that brand name in an IFU, you can look up that brand and you're like, oh, it's a quaternary ammonium. We're already using a quaternary ammonium. So that is perfectly acceptable.
And thank you. And we have another question. Do state survey agencies use GlowGerm when doing an infection prevention survey?
They do not. They do not. This would be just a performance improvement for us.
Perfect. Christine did clarify now in regards to the biofilm, sinks in general, not specifically the spigot or the drain. I didn't realize there was a difference.
Right. So this is kind of spinning us off a little bit, but when we are talking about biofilm buildup in the plumbing system, that is when we start thinking about Legionella and concerns about Legionella. Legionella loves to live in biofilm. So the biofilm can actually, it does accumulate in our spigots, in the faucets. And so if you're involved in any kind of testing and you have a spigot that consistently tests for Legionella that you're not able to remediate, it probably is biofilm buildup in the faucet, and it's time for facilities to change the faucet. When we're talking about biofilm that's down the drain, like we wash our hands and the water goes down the drain, there is nothing we can do about that. And I would not worry about remediating that at all. That is not getting us sick. We're not catching anything from biofilm in the drain unless we're down there playing with it, which I can't imagine. But yeah, I would not worry about that. If we're worried about any kind of film on our sinks, like not cleaning properly our sinks, well, that's a discussion with your supervisors in environmental services.
Perfect. Thanks so much, Bernie. So we are a bit over time. Well, I thank everyone for joining us. I have our contact information up here. If you have any questions or need any additional assistance with your quality improvement initiatives, we're here to help support you. We do have a live replay of this session again that's going to be played tomorrow at 3:30. So if you know anyone who would benefit from this session, please encourage them to come to the session, the replay tomorrow at 3:30. And we also have our live session on this Thursday for IP3. So we'd love for you guys to come to that as well. I will be sending out the slides to this presentation after this session today. So be on the lookout for that. And before I close the session, if you could just let us know if you thought that if today's session was helpful, it would be very much appreciated. Thank you so much, everyone.